Thank you very much, Lou, and I want to thank Shiv and Jeff for the really kind invitation to speak here. This is really kind of a summit of who's who in the neural control field, and I'm honored to be part of it. So we've been working in the area of neural control of the circulation for a long time, and some of our early work related to the cardiac sympathetic afferents. And lately, I want to show you some of the more recent data that we have that relates the importance of, perhaps the importance of these particular set of afferents on both autonomic regulation and cardiac remodeling. So, Bob Foreman set me up very nicely earlier today by talking a little bit about cardiac pain and the cardiac pain pathway, and I won't spend a whole lot of time, but the point is that these cardiac afferents that signal the sensation of cardiac pain apparently do much more than we have ever been led to believe. And in the setting of chronic heart failure, we've known for a long time that there are abnormalities in arterial baroreceptor input, that baroreceptor sensitivity is depressed, and arterial chemoreceptors seem augmented, so they tend to drive sympathetic outflow. Also, cardiac afferents that are sensitized appear to do the same thing. There are abnormalities in vagal mechanoreflexes as well, and this is pretty old data now that has been shown in a variety of species and models. Now, this is one of Bob Foreman's pictures from a book that we published many years ago showing the pathway by which many of these cardiac sympathetic afferents take. And as we've already heard today, the dorsal root ganglia seem to be where the cell bodies are. They go through the spinal cord and then up in the spinal thalamic tract, some of them in the spinal reticular tract. And interestingly, these afferent pathways give off neurons to the brainstem, some in the hypothalamus, and translate through the thalamus and then ultimately up into the cortex, where we have sensation of pain. And the whole idea of referred pain was discussed earlier today very nicely by Bob. So the cardiac sympathetic afferents themselves have been shown to be responsive to a variety of stimuli, many of which we see in increased levels during ischemia. Hydrogen ion, oxygen radicals, potassium, lactate, ATP, prostaglandins, bradykinin, substance P, CGRP, and of course the exogenous substance capsaicin. Substance P seems to have drawn a lot of interest. That I agree with Drew that it's not all about substance P, but I think substance P tends to be important in some of the inflammatory things that happen when these afferents are activated. So this slide is meant to just depict the variety of things that happen when these cardiac sympathetic afferents are activated by a variety of stimuli, some immune, peptides that are released in the ischemic area, things as simple as hydrogen ion, etc. And as we know and we've heard about, there are TRP receptors, primarily TRPV1 receptors located on these endings. Activation of these receptors depolarizes the neurons largely by opening a calcium channel, and we can get activation through neuropeptide release of a variety of other neurons back in the dorsal root ganglion and the spinal cord. And this pathway probably mediates most of the sympathoexcitation that one sees during these events. The other thing that's also been appreciated is that these peptides tend to both be vasodilator and change permeability. They act on endothelial cells. And once the substance P activates the NK1 receptor, there can be plasma extravasation, which mediates neurogenic inflammation and a variety of other things. CGRP may play a similar role. So activation of these afferents have a dual role, both in augmenting sympathetic outflow and in modulating inflammation locally. So this is a relatively old study. Again, Bob Foreman and Peter Schwartz, Lowell Stone, and Buzz Brown participated in this study, in which they simply looked at arrhythmogenesis following a coronary artery occlusion in a vagotomized preparation. This is in the dog. And during coronary occlusion, there were a variety of arrhythmias that were induced, and you can see them here, both PVCs, runs of tachycardia, etc. However, the interesting thing is, after dorsal rhizotomy, much of these arrhythmias were reduced. And this finding rose the idea that there are afferents that go through the dorsal roots that may participate in modulation of sympathetic outflow to the myocardium as a pro-arrhythmogenic pathway. And this has been reproduced many times by other investigators in a variety of different models. So some years ago, in a dog pacing model of heart failure, chronic tachycardia model of heart failure, we showed that if one puts bradykinin onto the surface of the heart, simply soak a piece of filter paper in bradykinin, put it on the surface, on the epicardium, and look at the change in blood pressure and, in this case, renal sympathetic nerve activity in normal animals or in animals with heart failure, find there's augmented responses in animals with heart failure. And you can see the mean data here, which tends to be dose dependent. Similarly, one can show the same thing for capsaicin. So in a heart failure animal, the response in terms of sympathetic nerve activity is increased with capsaicin. And more importantly, if one takes, and these were, again, vagotomized animals, and simply puts lidocaine onto the surface of the heart, we can see a reduction in basal sympathetic nerve activity simply with a lidocaine. So since they're vagotomized, the assumption is that we are blocking cardiac sympathetic afferents, which tend to be distributed towards the surface of the myocardium. In fact, if you record the afferent discharge from these fibers that we did some years ago in conjunction with Wei Wang in our lab, you can see that in response to capsaicin or bradykinin, there's an increase in discharge in heart failure, in these pacing heart failure animals, compared to sham controls. So in the last several years, people have been very interested in denervation as a modulatory mechanism for a variety of disorders, including hypertension. There's vagal stimulation for heart failure and controlling arrhythmias. And more recently, carotid body denervation has been introduced as a potential way of reducing sympathetic outflow and impacting not only the heart failure state, but hypertension as well. But there's been less work done on the cardiac sympathetic afferent reflex because it's pretty hard to denervate these afferents. And Bob told you this morning about referred pain from skin and various dermatomes and how that impacts on similar spinal thalamic tract cells, so we get pain. So one of the strategies that we entertained is whether we could intervene here, right here at the nerve ending, and reduce input from these cardiac sympathetic afferents, which we know are augmented in the setting of chronic heart failure. Now, this is not a sympathectomy for reducing cardiac pain is not a new thing. It's been tried before in '53. This particular study, removal of the T1 to T4 sympathetic chain, was pretty efficacious. It actually reduced pain and probably reduced arrhythmogenesis also. For a variety of reasons, this technique was abandoned for many years, and it is now probably employed only in the most severe resistant cases of arrhythmias. So this molecule came along, and you've already heard a little bit about resinoviratoxin, or RTX. So this is an interesting molecule that activates TRPV1 receptors on sensory afferents, especially those attached to C fibers, nociceptives in the myocardium. Comes from this cactus-like plant that's found in a couple places in the world, Nigeria, Morocco, and it has 16 billion Scoville units. For those of you not familiar with the Scoville scale, this is shown here, and you can see pure capsaicin is about 15 million. So this is, in orders of magnitude, more potent as an activator of TRPV1 than the most potent substance that we know now. So we took advantage of this technique so this is the TRPV1 receptor. And I just want to show you that this is a receptor that has 6 transmembrane spanning domains. It has a very large pore between S5 and S6, and most of the cations that flow through this is calcium. And you can see by looking at the internal domains is that there are a variety of signals that bind to these proteins. And if you look at this list, many of them are increased during ischemia and following a myocardial infarction. You can see RTX binds here at this S5 domain in this loop, and capsaicin binds at a variety of other places throughout the molecule. So we thought that RTX might be a good way to ablate these specific type of neurons by calcium toxicity. So in some preliminary data, we took a look at the thoracic DRGs, and we showed that if you look at TRPV1 expression, we find that in the setting of heart failure, and this is now post-myocardial heart failure, the TRPV1 expression is increased. And IB4 is a marker for C-fiber afferents, and you can see that there is an increase in TRPV1 in both C-fiber and non-C-fiber afferents. So there seems to be ubiquitously expressed and markedly augmented in the post-MI state. So we did a simple protocol in which we simply painted RTX onto the surface of the heart at the time we made a myocardial infarction in an effort to remove many of these cardiac sympathetic afferents, at least those in the surface and maybe in the lower 500 microns or millimeter or so. And the protocol is shown here. Animals were randomized. They were MI or sham operated, and then they were randomized to either RTX or vehicle. At the time we made the coronary ligation. After 2 weeks, they were echoed. We followed them with serial echoes over time. At 7 weeks, we put them in metabolic cages to collect urine and measure excreted norepinephrine. And then at 9 to 11 weeks, we did terminal experiments to measure sympathetic nerve activity and ventricular function. So just to show you that we can actually eliminate the TRPV1, you can see that a week after RTX, there was very little TRPV1 staining. This is a pan-neuronal marker, PGP 9.5, and 6 weeks later, there was still very little in the way of TRPV1. And this is also somewhat dose-dependent. At lower doses, you still see some TRPV1, and as you increase the dose to about 50 micrograms per ml to the surface of the heart, there's pretty much uniform destruction of the TRPV1. And then if we test the functional reflex effects with either capsaicin or bradykinin, you can see there is a dose-dependent reduction in the response, both for mean arterial pressure and renal sympathetic nerve activity. And if we do a time course over time, we find that the response to capsaicin is pretty well depressed out to 12 weeks with some return at 26 weeks. The bradykinin response does come back at about 26 weeks. So this is not really permanent, but it's quite long-lasting. And if we look at sympathetic nerve activity, we measured both renal and cardiac sympathetic nerve activity in both sham animals treated with RTX and in heart failure. The first thing to note is heart failure animals have fairly high levels of sympathetic nerve activity. Following RTX, it's much lower, and you can see that that both this is the response to capsaicin and bradykinin, and you can see the response to these agents is almost completely obliterated following RTX. Baseline renal sympathetic nerve activity is normalized. Cardiac sympathetic nerve activity is also normalized. And if you measure an index of global sympathoexcitation, urinary norepinephrine, it's also much lower at this was done at, as I said before, at around 7 weeks. We believe it's sustained for much longer than that. Baroreflex function is another measure of sympathetic tone, and we looked at arterial baroreflex function in response to both heart rate responses and the renal sympathetic nerve activity responses. And these are the average curves and the peak gains or the first derivatives of these curves. And you can see that in heart failure, markedly depressed, following RTX, baroreflex function is quite normalized. Now, one of the things that piqued our interest is that when we did hemodynamics, when we looked at, for instance, left ventricular end diastolic pressure in these animals that were treated with RTX, it was relatively low compared to our sham animals. And this was in spite of the fact that infarct size was about the same. And this really puzzled us a lot. And when Hanjun Wang, my partner in crime, showed me these data originally, I didn't believe them. And I said, you know, do another one, and do another one, and do another one. So we did about 10 or 12 of them, and it was always the same. There were quite low end diastolic pressures. And negative DPDT seemed to be improved, although positive DPT was not much improved. So one of the ideas that struck us is that maybe there's some change in the compliance of the heart or alterations in remodeling as a result of the RTX application. And if you look at these hearts, here are the sham hearts, here are sham RTX-treated hearts, not much different. Our infarcted hearts are very big. They have a very clear scar, so you can see here. And following RTX, while the scar is about the same, heart size is smaller. And that led us down a path of looking at remodeling and fibrosis in the non-infarcted zone in RTX. So if you look at some of the echo data, we showed that RTX tend to reduce the progression in both dimensions and volumes here, end diastolic and systolic dimensions, even though ejection fraction was pretty much sustained at a low level from about 2 weeks out to 6 weeks in this case. And then if we do pressure-volume relationships here, we found that end systolic pressure-volume relationships were really not much different, which goes along with similar DPDTs. But if you look at end diastolic pressure-volume relationships, much flatter following RTX in our heart failure group, suggesting that the heart is probably much more compliant, and you can see the mean data here showing really no improvement in end systolic pressure-volume relationships, but a marked reduction in end diastolic function. The other thing that we noticed, again, is that there was an improvement in negative DPDT, which I showed you before, but even though systolic function was not improved, cardiac reserve seemed to be increased. Because if you look at the response to isoproterenol in RTX-treated animals, there was augmented responses to isoproterenol, even though it was much below our sham group. So that suggested to us that there may be, in addition to the remodeling that's going on, an impact in beta-adrenergic signaling in the heart. So we started to look at fibrosis, and we had several different markers of fibrosis. So total collagen, typified by picroserous red staining, is shown in the remote area and in the intraventricular septum. And you can see here that following RTX, there's less collagen deposition. Well, here you can see it here better. less collagen deposition in the intraventricular septum and in the left ventricular remote area. And the mean data is shown here for both septal and remote. Other markers such as alpha smooth muscle actin was lower in both the LV and the septum. Mean data is shown here. Fibronectin, another good marker of fibrosis, was very low in the left ventricular septum, in the remote left ventricle and in the septum. And another marker of fibrosis, the TGF-beta1 receptor, was also reduced, not quite to the same degree as some of these other markers. But very interestingly, the isoproteirenal data that I showed you on the previous slide had a corollary in the fact that the beta-adrenergic receptor was upregulated. And we hope and we think that this reflects a reduction in sympathetic outflow to the heart following RTX. So as I said earlier, the TRPV1 receptor mediates neuropeptide release, which has effects not only on sympathetic nerve activity, but also on adjacent vascular function, capillary permeability, plasma extravasation, and inflammatory cells that move into the target of ischemia. And we felt that this was also a potential mediator of the RTX effects. So this is unpublished data, and we're very excited about it. If you apply bradykinin onto the surface of the heart with a pledgelet of filter paper, and then you perfuse the animal or inject the animal with the Evans blue, kill the animal, clear, you can see plasma extravasation from the albumin labeled Evans blue. And you can see this very nice wheel exactly where we put the bradykinin, and you can see the same thing with capsaicin. Following RTX, that plasma extravasation is completely eliminated, suggesting to us that release of neuropeptides that alter permeability is important. Also, if we block the NK1 receptor with this spantide 2, we also block the response to, in this case, capsaicin. But more importantly, perhaps, the response to myocardial infarction can also, the plasma extravasation in response to myocardial infarction, both early and later, can be blocked with RTX and partially blocked with spantide 2. Inflammatory mediators, cytokines such as IL-1 beta and TNF alpha are reduced following RTX. So there's, again, a multipotent effect here. Now, the extracellular matrix we think is very important in the remodeling process, and many people have studied this for longer than we have. And if you look at the collagen weave that happens around the myocyte fibrils, in normal animals, they tend to be very, very thin and fibrous, and this is now in the peri-infarct zone. In heart failure animals, the collagen fibers become thick, they become somewhat disorganized. And what we found is that after RTX, those thick collagen bundles tend to be normalized. And we tried as best as we could to look at similar areas in the peri-infarct zone as we could. And how does the extracellular matrix get reorganized? We believe it gets reorganized by changes in metalloprotease activity. So the two matrix metalloproteases that tend to be implicated in cardiac remodeling are MMP9 and MMP2. And if you look at zymography plots in heart failure, there's clearly upregulation of both MMP9 and MMP2 activity. And after RTX, that activity tends to be somewhat normalized, and similar for the protein, at least for MMP2. So we think that modulation of MMP activity that may be mediated by the action of neuropeptide release from cardiac sympathetic afferents plays another role in the chronic remodeling process. The other thing that was surprising is apoptosis. So one marker is tunnel staining, and if you look at tunnel staining, you find that after RTX, while apoptotic activity is not normalized, it's certainly reduced in the infarct area, in the peri-infarct area, and in the remote areas. Another marker of apoptosis is cleaved caspase 2. You can see that normal animals have very little cleaved caspase 2. Heart failure animals have lots of brown staining. Following RTX, there's much less of the cleaved caspase 2. So RTX treatment, at least epicardial RTX treatment, is doing a lot of beneficial things. So what about survival? Do these animals get any benefit? Do they live any longer? And they do. These are survival studies taken out 26 weeks, so almost 6 months, and you can see that there's no question that there's an improved survival profile in RTX-treated animals compared to sham. Now, I just want to finish up with a few slides of new things that we're doing. So epicardial application is one thing. Is it doable in humans? How would it be accepted? I think it is doable in humans, but it may be a little bit more difficult. But epidural administration of all sorts of things are being done in humans every day. And we thought we would take a look at whether blocking or destroying dorsal root ganglion neurons by epidural administration would have an effect as well. So if we give RTX in the T1 and T4 dorsal roots with a catheter that we insert lower down, push up, and eject about 50 microliters into each of the dorsal roots, we find that, that we can indeed reduce a TRPV1 expression by RTX, and you can see that this lasts for a very long time. The change in blood pressure in response to bradykinin or capsaicin is long-lasting after epidural administration. If we record sympathetic nerve activity from these animals, as I showed you earlier, heart failure animals have high levels of cardiac sympathetic nerve activity, and epicardial RTX reduces that. But much to our surprise was that epidural RTX reduced it even more. We got a very large reduction in cardiac sympathetic nerve activity and renal sympathetic nerve activity. And you can see that mean data here. I won't talk much about another experiment that we're currently carrying out in which we're trying to selectively inhibit substance P-containing neurons with saporin substance P, and that seems to have a bit of a mixed effect. So I won't spend a whole lot of time on that. Now, what about survival in the epidural application? So we don't have as many animals, but this is the epicardial, and this is the epidural. The profile looks very similar. Out to about 26, 27 weeks with smaller numbers of animals, but you can see that those animals treated with epidural RTX seem to derive a significant benefit. So just in summary, we think that these cardiac sympathetic afferents can be targets, not at the exclusion of other things that we've already heard about and will hear about, but we can impact both the sympathoexcitation as well as the cardiac remodeling and some of the inflammatory things that happen following myocardial infarction and probably other forms of heart failure as well. So I'm going to stop here. I want to just acknowledge two people. First of all, Han-Jun Wang, who's in the audience, and you can ask him whatever you want. He's fantastic. He's the driving force behind a lot of this. Kurt Cornish was very helpful in helping us make large numbers of infarcted animals, so we can use them for these studies. Thank you very much.